This meeting is now being recorded.
All right, we're back. So we're going to talk about Dandy-Walker malformation. So when we were talking about the cerebellar vermis in the normal image section, so the area that connects the two lobes of the cerebellum and how important that was, Dandy-Walker is going to show us why that's important. So Dandy-Walker malformation is an anomaly of the posterior fossa with cystic dilation of the fourth ventricle, complete or partial agenesis of the cerebellar vermis, and elevated tentorium. So sonographic appearance, we have the superior displacement of the cystic fourth ventricle, displacement of the frequently hypoplastic cerebellar vermis, and elevation of tentorium above normal position. So we have the hindbrain here, the back of the brain is a lot, displaced quite a bit and very abnormal. In a sagittal plane, we're going to see the superior displacement of the cystic fourth ventricle, displacement of the hypoplastic cerebellar vermis. So all of these things here is going to be very obvious on ultrasound. So we have our normal head here. We have our nice, pretty cerebellum back here, and this is Dandy-Walker. So these are the lobes of the cerebellum, but where this arrow is pointing is where the cerebellar vermis should be. So there should be connection right here, but there's not, it's absent. And the fourth ventricle is in this area here, in the area of the cisterna magna. So it's definitely very dilated. So this malformation will prevent blade cerebellar lobes due to the absence of the cerebellar vermis. So since there's nothing connecting them together, they're going to be pointed out kind of away from each other. So if we remember, the measurement of the cisterna magna in the normal fetus is less than 10 millimeters. So this area right here. So we measure outer cerebellum to inner occipital bone in an AP plane. So this area back here behind the abnormal cerebellum is clearly abnormal and much bigger than 10 millimeters. So very abnormal measurement. So schizencephaly. So this is a condition with disordered neuronal migration that results in unilateral and bilateral clefts in the cerebral hemispheres. So neuronal migration having to do with the embryologic development of the brain. It is abnormal. So it causes these big kind of holes and clefts in the brain tissue. So sonographic appearance, we're going to have fluid-filled clefts, so just like we saw in that CT, so indents into the brain tissue. And these clefts are lined by gray matter with cerebral cortex. So we have kind of a protrusion here, but the lining of these clefts here is gray matter of the brain. Our nice normal brain here. And then schizencephaly. So this is the lateral ventricle, I shouldn't say normal. The frontal horn, and then you can see it's like a big chunk taken out of the brain right here. So this never developed. So this is this area looks like it's communicating with the ventricles, causing that fluid. So this is an area of schizencephaly. And then we have lissencephaly. So cortical displacement, or excuse me, cortical dysplasia resulting from impaired neuronal migration during development. So again, having to do with embryologic development of the brain, specifically this in between 12 and 16 weeks of pregnancy. So schizencephaly is something that causes the brain to be smooth instead of having those kind of grooves of the sulci and the gyri. So depending on the time of disruption, the fetal cortex can completely lack sulci and gyri, so it can be completely smooth. So in this image here, this is a cross-section of the brain, so you can see how smooth it is. Usually we see those indents everywhere, but it's very smooth, very abnormal. So this would be lissencephaly. So sonographic appearance, so smooth cerebral surface. So this is a sagittal image of the head. This is brain tissue here. Look how smooth it is all the way around. That's definitely abnormal. So the sulci normally remain smooth until about 20 weeks, as we were talking about earlier in the embryology, and when we can see things on ultrasound. So we can usually see those sulci beyond 28 weeks. So we would see those indents within the outer portion of the brain, and the also the inner portion too. We would see those. So smooth surface beyond 28 weeks should raise concern. So we have our normal head. So this would be an 18-week fetus. So you can see how we have this indent here. So again, still pretty smooth. We don't have a bunch of indents all along the head because we're still pretty early, but this is 28 weeks. And you can see that this is actually even less of a kind of an indent than this one is. Excuse me. And especially all the way along here, very smooth. So that's very abnormal. It is a pretty difficult diagnosis to make via prenatal ultrasound. So as we know, as the pregnancy progresses, those bones will start to ossify more. So we get that shadowing in the head from the cranial vault. So it's difficult to see the outer borders of the brain later in pregnancy. So this is hard diagnosis to make. So this is just a normal brain here with all those kind of indents and sulci and gyri present, and then there's lissencephaly over here. So look how smooth this is. So we do have kind of big areas of indentation, but they're definitely abnormal, and there should be a lot more than that. All right, so we're going to talk about cephaloceles. So cephaloceles are protrusion of the meninges and frequently brain substance through a defect in the cranium. So this is central nervous system tissue protruding through a hole in the head. There are two types. So there's an encephalocele, which contains brain, and then a meningocele, which only contains meninges. So meningocele is going to look like a defect still. It's going to look like just a membrane in there that's filled with fluid, so just like a cystic outpouching. Where an encephalocele is going to have that cystic outpouching as well, but that's going to be full of brain tissue. So this is a neural tube defects that results from a defect in the closure of the tube during embryology. So sonographic appearance. So this is obviously not an ultrasound, but we can see a very obvious defect right here. So there's going to be a pericranial mass. So it could be here in the front of the head. A lot of the times they're kind of towards the base of the head, kind of in the area of the top of the neck there. It's not going to be covered by bone, and there's going to be a defect in the skull. So that's what allows the brain tissue and the meninges and the CF defects. So this is a normal ultrasound. And this is an encephalocele. So we have the head here with that protrusion out back. So we kind of have that that tissue inside, I should say, is not quite anechoic. So we would assume that this is probably partially brain tissue. But it can be difficult to diagnose on ultrasound between the two. So normal head, and then we have a classic meningocele here. So same view of the head, and then we have this defect back here that's just containing CSF, so anechoic. Definitely no brain tissue within there. And like I was just saying, so difficult to distinguish encephalocele and meningocele sonographically. So we have an encephalocele here, so super abnormal, and then a meningocele. So they can look the same. That fluid's not always going to be completely anechoic. It could have some debris, which could make it look like brain tissue. So it's can be hard to diagnose between the two, but it's very obviously there, even if you can't diagnose or distinguish between the two. So often associated with microcephaly, hydrocephalus, and ventriculomegaly. So kind of like an encapsulation or gastroschisis. So if those organs are outside of the body, that belly is going to be smaller. So if that head tissue is outside of the head's going to be smaller. So that's why we have the related microcephaly, hydrocephalus, and ventriculomegaly, just because that brain tissue is abnormal because it's not in the right spot, causing that fluid to build up. All right, so anencephaly. So this is a pretty severe defect. So it's a defect in the occiput of the cranium involving the foramen magnum with marked retroflexion of the fetal head and frequently shortened spine. So this is, you can see the image here, but this is baby's head is tipped way back. So it looks like they're looking towards the sky, and it's stuck there due to that defect. This defect usually occurs during the 3rd week of gestation, so this happens during the embryological process. So in ultrasound, we're going to see a retroflexed neck that doesn't leave that position. The cranium and chest can sometimes be visualized in the same transverse image if the head is tilted back far enough. And then it's an inability to visualize the entire spine. So if that head is tipped back, that spine is going to be bent in a weird plane, and we're not going to be able to see it all in one image. So we have the baby here. This is the chest, and then the neck is almost continuous with the chest because the head is tipped so far back here. So we have our normal fetus here: profile, body, bottom, legs. And then anencephaly, we have the head. We can see it's tipped way back. This is the back of the head touching the back of baby. So head, body, bottom, and legs here. All right, so Arnold-Chiari malformation. So this is a group of anomalies of the hindbrain that prolapse below the level of the foramen magnum. So the hindbrain containing the cerebellum and all the other structures goes below the foramen magnum, so almost protrudes into the spinal column itself. This is almost always associated with spina bifida. So that spina bifida is spinal tissue that is protruding out of the back. So if that's outside of the back, this posterior part of the brain is going to fall down because that protrusion out of the back is going to make going to make room, I should say, for these structures to be lower. There are 4 types. So type 2 is the most important. We'll go over all 4 of them here, but type 2 is what you want to remember. So type 1, we have it's mild. So cerebellar tonsils displace more than 4 millimeters into the foramen magnum, and the posterior fossa contains the 4th ventricle. So type 2, displacement of cerebellar tonsils, parts of the cerebellum, 4th ventricle, pons and medulla oblongata through the foramen magnum into the spinal canal. Hydrocephalus and myelomeningocele accompany in 90% of cases. So myelomeningocele, aka spina bifida. So again, rarely found without spina bifida. Type 2. Type 3, this is the most severe form, so large herniation of posterior fossa contents within the myelomeningocele end, with an associated myelomeningocele and hydrocephalus, I should say. And then type 4, we have a hypoplastic cerebellum with further herniation of the brain into the spinal canal. So pretty significant defect. Type 2, most related to spina bifida. So ultrasound findings of Arnold-Chiari malformation type 2. So displacement of the cerebellum inferiorly changes its shape and effaces the cisterna magna. So our cerebellum is going to look different, and the cisterna magna is usually obliterated. And we'll take a look at those images here in just a second. So type 2 has to do with a variable displacement of a tongue of tissue derived from the inferior cerebellar vermis into the upper cervical canal. So again, that falling down into the cervical canal of the cerebellum. So there are 2 signs associated with Arnold-Chiari malformation type 2. So the first one is the banana sign. So this represents a downward displacement of the cerebellum. So the cerebellum does not look like a peanut anymore. So right here is the cerebellum. It looks like a banana. So we have a flattened, centrally curved banana-like appearance of the cerebellar hemispheres. So no longer kind of bulging out in both planes. It's flat towards the posterior and then bent inward towards the anterior, that's looking like a banana. So this is the banana sign. And then we have the lemon sign. So this has to do with the how the head looks, the cranial vault. So caudal displacement of cranial contents within pliable skull will cause this lemon sign. So scalloping of the frontal bones make it look like a lemon. So indents almost of the frontal bones here. So lemon sign and banana sign. So the fruits are associated with Arnold-Chiari malformation. So we have a normal head here, nice round cranium, nice cerebellum, and then we have Arnold-Chiari type 2. So we have that pointed frontal skull here with the indents on either side, making it look like a lemon. And then the cerebellum, banana sign here, the cisterna magna is obliterated. So obviously abnormal. All right, so ventriculomegaly. So we've talked about this before. So abnormal increase in the volume of spinal fluid in the cerebral ventricles. So there are many different causes of ventriculomegaly. It's very common finding in abnormal conditions. It can be isolated as well. So causes can be intraventricular, so happening within the ventricle, or extraventricular, so something that's influencing the ventricle and the cerebral spinal fluid to increase. The most severe form of ventriculomegaly is hydrocephalus. So that's ventriculomegaly with increased intracranial pressure and head size, so really dilated ventricles within the head. So enlargement of the ventricles greater than 10 millimeters. So we know that that measurement of the lateral posterior ventricle should be less than 10. And cerebral spinal fluid displacement of choroid plexus. So when there's extra fluid in the lateral ventricles, those choroid plexus that fill the lateral ventricles are just going to kind of fall because they're not supported by the back wall of the ventricle. And they're going to look almost dangling. So this is what's called a dangling choroid plexus. So this is seen with severe ventriculomegaly and hydrocephalus. So we have our normal head here. We have our nice normal measurement of the lateral ventricle. And then here we have ventriculomegaly. It's kind of fuzzy, but it looks like it's 12.06 millimeters. So we're definitely above 10. So that's an abnormal finding of ventriculomegaly. So we have our dangling choroid plexus. So normal, we usually have the choroid plexus within the lateral ventricles kind of parallel with the midline falx. And the dangling, when they start to dangle and there's increased fluid in the lateral ventricle, they're now starting to be perpendicular to the midline falx. You can see how this is definitely not parallel with the falx. It's starting to become more perpendicular. So that is a dangling choroid plexus. So again, we want lateral ventricle measurement of less than 10 millimeters. We measure that inner to inner posterior ventricle, perpendicular to the ventricle, crossing the tip of the choroid plexus. So that represents the widest part of the lateral ventricle. Anything between 10 and 15 millimeters is considered mild ventriculomegaly. Anything over 15 millimeters is considered severe, and it has obviously the worst outcomes. So this is a finding that is not that uncommon. It can be isolated, like I said, but it can commonly be associated with other conditions. It can commonly be associated with maternal infections and toxins. So if this is a finding in the fetus, the mom usually has a serum panel drawn to make sure that she doesn't have any viral infections or bacterial infections. If she doesn't, then further investigation will happen to try and figure out what is causing this to happen. So choroid plexus cysts, so this is another common finding within the fetus. So sonolucent areas within the choroid plexus of the lateral ventricles. So we know that the choroid plexus are the areas that make the spinal fluid. They're echogenic teardrop shape within the lateral ventricles. So a choroid plexus cyst is an anechoic area within that choroid plexus. So very easily distinguishable here. So since the choroid plexus make the spinal fluid, it's kind of makes sense that there could be fluid deposits within the choroid plexus itself. So that's what creates those cysts. It happens with 1 to 6% of all pregnancies, so it's very common. They're usually of no clinical significance, especially if they're isolated. And if we see them at the fetal survey, they're usually resolved by the end of the second trimester. So it's happened many times. Just as a personal example, at MFM, someone is scanned in an outside office, and they see choroid plexus cysts on their ultrasound, and then they're referred to us for a scan to take a better look at them, and they come to us and they're gone. So they do resolve quickly. They can happen throughout pregnancy and throughout adult life. So I can have a choroid plexus cyst right now and not even know it. They're very benign. They do have an association with trisomy 18, so that's kind of why we talk about them. If they're isolated, if the patient's low risk, if there's normal serum screening, then this is just a finding we don't even really care about. But it does occur with the syndrome of trisomy 18. So if there were other findings, we would be more concerned about this. So sonographic appearance, so that anechoic, well-circumscribed structure noted within the choroid plexus, so this area right here. They can be unilateral or bilateral. They can be very small, very big. It's pointless to measure. There's no normal measurement of a choroid plexus cyst. If it's there, it's there. If it's not, it's not. So no need to measure. Big or small is not an issue. It doesn't affect brain function or development or anything. So we have our normal head here, and then we have our bilateral choroid plexus cysts. So these are on the bigger side. You can see kind of within the area of the choroid plexus. So if these are found in isolation, I was just talking about normal low risk patient, normal serum screening. They're considered a normal variant, so very similar to a birthmark. So not everyone has a birthmark in the same spot, but it's not harmful, and it's not going to cause any kind of trouble down the road. It's a very benign finding. So we were just talking about this. So if your patient presents to the ultrasound department with a maternal serum screening showing low HCG and low unconjugated estradiol, and you found choroid plexus cysts on the ultrasound, what may this be indicative of? So that's trisomy 18. So low HCG and low UE3 at a serum screen is can red flag those findings for an increased risk of trisomy 18. So CP cysts are considered a sonographic soft marker. So soft markers mean that finding them doesn't mean immediate worry for a certain condition. It's just something that's kind of can be associated with a certain syndrome. So not diagnostic of trisomy 18, but can be part of that kind of process. All right, so we're gonna go and move on to the fetal face. Was a lot of information, so take breaks as you need to. I just realized that I forgot to put the stars on the slideshow, so when I put it on Canvas, I'll make sure that I edit it and put the stars on the PowerPoint slides that are extra important and could be seen on future board exams. So hypotelorism, so we're going to talk about the eyes. So this has to do with the distance between the eyes. So decreased intraorbital distance, so the eyes are too close together. This is almost always associated with other severe anomalies. If you remember when we were talking about holoprosencephaly, we were talking about abnormal eye placement, specifically cyclopia, but this can be commonly associated with holoprosencephaly, so the eyes that are too close together, hypotelorism. So sonographic appearance, decreased intraorbital distance, so the area between the orbits, so kind of the measurement crossing the nose, and then those associated anomalies that it's most likely seen with. So we have a normal head here. We're looking at the head in transverse cross section kind of from the top down, so we can see those eyes either side. And then we're looking at the fetus in the same way. So the nose here, eyes are here. They're so close together that it almost looks like they are connected, which they could be. Eyes don't have to be separated if they're extreme, on the extreme end of hypotelorism, they can be connected in the middle there. And then hypertelorism on the other end of the spectrum, so that's when the eyes are too far apart. So increased intraorbital distance, so the area that crosses the bridge of the nose. This more often occurs in isolation. It can occur with other anomalies or as part of a syndrome as well. In extreme cases, it can be associated with mental retardation, orbital teratomas, encephalocele clefts, and agenesis of the corpus callosum. The syndromes associated with hypertelorism, so Apert syndrome, Crouzon syndrome, Noonan syndrome, Penna-Shokier syndrome, and Pfeiffer syndrome. So just some examples of the kind of syndromes that can present with hypertelorism. So sonographic appearance, increased interorbital distance, so far apart eyes, and then those possible associated malformations. So obviously the CT that looks very, very weird with the eyes that far apart. So we have our nice normal eyes here, and then hypertelorism, so these eyes are further apart than they should be. The measurement of the interorbital distance is from here, across the nose to here, so further apart than they should be. So we're just comparing hypo, too close, normal, and hyper, too far. So it can be difficult to diagnose on ultrasounds. So obviously very little difference in position of all of these eyes. So tricky one to make unless it's very severe hypo or hypertelorism. So what are these findings associated with? So cyclopia, possible cyclopia, so that's when the eyes, it looks like there's going to be two, but they're connected, and then hypotelorism, so there's too close. So we were talking about this already, so holoprosencephaly. is associated with those eyes that are too close, and eventually even just connected or just one. So how do you measure the distance between the eyes? So the interorbital diameter is the best indicator for telling if the eyes are in the normal plane. So you want to obtain an image of the fetus in a transverse plane at the level of the orbit, so you can see both of them, and you'll end up seeing the nose in between them in this plane. And then you just measure in between the orbits. So from here, across the nose to here. So this is, again, used to determine if there is hypo or hypertelorism. All right, so continuing with the eyes. So we have microphthalmia, which is decreased orbit size, and anophthalmia, which is the absence of the eye in the orbit. So anophthalmia is an absence of everything. So the optic nerve, chiasma, and all the tracts are absent. These can be isolated or part of a chromosomal anomaly. They can also be caused by an intrauterine infection. So microphthalmia, sonographic appearance, small orbit, one or both, orbital diameter less than the 5th percentile. So the size of the orbit measurement is very small. And then anophthalmia is the absence of an orbit or both. So this is an MRI of a fetus where one side we can see an eye and the other side it's absent. So we have comparison. So microphthalmia. So this is the measurement here, the orbital diameter, so measuring across the orbit. So this is a normal orbit, and look how little this guy is over here, so small. So one eye is affected. Then we have our normal eyes, and then anophthalmia. So we have an eye here that looks pretty normal, and then we have nothing, so missing. So macroglossia, so this is an abnormally large tongue that extends beyond the teeth or alveolar ridge. So we've talked about this before when we talked about Beckwith-Wiedemann syndrome. So Beckwith-Wiedemann syndrome is a syndrome of enlarged organs, so liver, spleen, kidneys is highly associated with macroglossia. It can also be associated with trisomy 21. So on ultrasound, the profile shows a large tongue that's kind of protruding, and it won't be seen going back into the mouth. It'll be outside of the mouth the whole time. So we have our normal profile, our lips here are closed, nothing's protruding out. This is a 3rd trimester fetus with macroglossia. The arrow is pointing to the tongue. We have one lip here, and that tongue is staying there. It's not going back in the mouth because it's too big. Here's another image. This is a very large tongue, so we can see it protruding out of the mouth here, and it is not going back in because it's too big. And then micronaphia. So this is a severely hypoplastic mandible. So either severely hypoplastic or absent completely. 40% of these cases are isolated, but they may be seen as part of a syndrome. So very small chin, very easy to see on ultrasound. There are certain trisomies that are associated with micronaphia. So if we remember, trisomy 13 and 18 can be associated with a small or absent chin. So the profile view with micronaphia shows a small chin and prominent upper lip. So if we remember from the online lesson, when we're looking at a baby in profile, we want to see the nose, lips, and chin all in the same plane. So we can see here we have the nose, top lip, bottom lip is tucked in, and chin is way back. So we're kind of at an angle here. So definitely not all in the same plane. If you were to look at this fetus coronally in a view of looking at the nose and the lips, You'd see the nose, top lip, and probably not the bottom lip because it's too far back, and then definitely not the chin. So that's a good view to use when we're trying to prove that there's a smaller absent chin. So our normal profile, so again, we want that nose, lips, and chin in a straight line, so we can see how that can happen here. And then micronathia, again, we have the nose, prominent top lip, bottom lip is tucked in, and chin is tucked in and very far back. So when babies are born, they can have some complications if they have a smaller absent chin. So why do you think babies born with micronathia have a hard time breathing? So since that lower lip and chin are kind of tucked in, the tongue may obstruct the upper airways during delivery, so can be kind of dangerous to the baby during delivery. So cleft lip and palate. So this is something that can be detected on ultrasound. So a defect in the lip and or the palate of the fetus. This is the most common craniofacial anomaly. And considered the second most common congenital malformation. It consists of 13% of all anomalies. So that's a lot. So you can either you could have a cleft palate by itself, a cleft lip by itself, or a cleft lip and palate together. So incidence of a cleft lip, so it may occur independent of chromosome abnormalities. Cleft lip and palate over half occur with other abnormalities, usually as part of a trisomy. So this cleft lip by itself has more incidence of occurring independently than the cleft lip and palate together. There have been 350 syndromes that have been linked to facial clefting, so that is a large list. So cleft lip and or palate are part of a multifactorial process. So clubfoot is the most frequently seen anomaly with the finding of isolated cleft lip or cleft palate, and polydactyly is the most frequently seen anomaly with the finding of cleft lip and cleft palate. So one or the other clubfoot is seen, and both polydactyly is seen. So here we have the incidence. So 50% we have both cleft lip and palate. 33% is a cleft palate, and cleft lip. This should be cleft lip is 17%. Excuse me. So cleft lip and palate can occur in part of the face, or can occur in any part of the face, but most often the nostril and central posterior palate are affected. In severe cases, the cleft lip and cleft palate extends through the hard palate and alveolar ridge, involving the nasal cavity and possibly the orbit. So that's a pretty severe case of a cleft lip and palate. Sonographic appearance. So we have a linear defect descending from the nose to the oral rim and distortion of the upper lip. So this is an image in a coronal plane. So we're just seeing the tip of the nose and lips. So tip of the nose, top lip here, bottom lip. So we want to see this nice and continuous. So we can see there's a defect right in the middle of the lip there. There are other adjunctive findings that can happen. So undulating tongue movements, hypertrophied tissue at the edge of the cleft, and hypertelorism can be associated. So these are just some images of a normal face. So we have our normal profile, our normal coronal nose and lips. So nose, top lip, bottom lip, chin, and then palate. So we can see the part of the palate here that ends towards the front of the face, and then this is the palate itself. So normal profile, cleft lip. The profile is going to be abnormal, even though the cleft is usually anterior to the face. The top lip is going to look odd in that profile view. So it looks like it's kind of protruding out in this image. And then we have our normal coronal, nose, lips, and chin. And then we have our cleft lip right here, and then extending into the palate, defect over here. So coronal and transverse views of the face are good to see this defect in. So coronal mostly for the lip and transverse for the palate. Here we have just a series of 3D images showing a cleft lip and palate. So we have, this is our acquisition image, so that image that we get the 3D information off of. So we have our cleft lip and palate right here. This is baby's tongue, cleft lip, cleft palate. So 3D is really helpful in the instances of cleft lip and palate. A cleft palate can be a lot harder to see on ultrasound than a cleft lip because it is deeper within the fetus, obviously. The cleft lip is superficial here. We can see that easily. But the 3D lets us slice back into the face to see the palate, and we can see that there's definitely a defect in there extending to the nasal cavity. What a cute little baby, little cleft there. Which trisomy is most associated with fetal anomalies like a cleft lip and or palate? So again, trisomy 13, highly associated with this. And that is it. That was a lot. So make sure you run through it again. As I said, I'm going to post the PowerPoint itself with the stars on it, so you guys can look through that and see the more important parts. If you have any questions, go ahead and send me a message. See you next week.